Hello, everyone. Thank you for tuning into our podcast. I am Dr. Supriya Mannepalli, Medical Director for Infection Prevention and Control at Northeast Georgia Health System. I have Dr. Patel from our urgent care, Dr. Alix Schnibben, our Clinical Quality Director for NGPG, and also the Pharmacy Director for Ambulatory side, and Dr. Maria Munoz, our Family Medicine faculty, joining today for a discussion on sinusitis. This is one of the very common diagnoses in the outpatient setting, and I was just looking up some statistics as we were preparing for the podcast, and I was just really, kind of knew that we use a lot of antibiotics for sinusitis, but I was looking at the data, and almost 31 million visits or adults are diagnosed with acute bacterial sinusitis in an year, and $2 billion healthcare cost per year. And majority of them actually get antibiotics. There was a survey, a study that was published that was a survey of urgent care providers where 100% of them said that they would prescribe an antibiotic if a patient is coming in with acute bacterial sinusitis. And when they surveyed patients, almost 70 to 90% of them also said they expect an antibiotic. Mm-hmm. So I think why this is important, why we're talking about this is because WHO estimates that by 2050, 8.3 million deaths per year are going to be due to antibiotic-resistant infections, and healthcare costs per year would be around $1 trillion. Mm-hmm. So you guys live this every day. I'm more in the outpatient setting. So I think hearing from all of you would be very important, that just share, each of you can share just a little bit about your background, what you do, and about these scenarios that you face in the outpatient setting. We'll start with you, Dr. Patel.
Sure. Yeah, so I've been working in the urgent care for the last 8-9 years, both in Chicago and then now here in Atlanta. And it's the same everywhere. Mm-hmm. I think it is, a lot of times it is the expectation. I think a lot of the providers, most providers know that, this is a viral infection about 80% of the time. Antibiotics are indicated at a certain point when you go around maybe 8-10 days, and it's not getting better. But the expectation that patients also have, and this I think it's almost like a learned thing that I need an antibiotic to get better. I need a steroid for it to get better. People don't want to wait for things to get better. They don't want to be sick. They want to get ahead of it, which are all these things that we hear very frequently in the outpatient setting. So it kind of ties the hands of the providers where, even though you provide the education, the expectation is they want to leave with something. Yeah. And it is very unfortunate. It definitely is very unfortunate. I think many times, if patients have a little bit of patience, we can probably combat these statistics and improve our prescription rates. But it is a very hard uphill battle.
Yes, it is, and I think that's why I think it's not just educating the providers, but educating the community about how are these infections treated, given that, as you said, majority are viral. I was looking at some statistics, and they said only 0.5 to 2% are actually bacterial. And and then even among the bacterials, majority are self-limiting. Alix, what's been your...
Oh, absolutely. So having been at NGPG for 7 years now during the quality side and the ambulatory side, we have had the luckiness of the individuals at this table creating an antibiotic stewardship ambulatory focused team. And one of the things we did is we have our own data now. So what's not good about our data is it's way above the national average for prescribing rates. So I was recently reading, actually last night, it's about 79% of the population will leave with an antibiotic when we look at some data from 2023. When we look at our data in the last fiscal year, 95 to 100% of our patients with sinusitis leave with an antibiotic. So it's pretty high here. So it's something that we have. But when you dig deeper into it, you get some things around duration, going over the 5 days, and then the antibiotic selection doesn't meet first-line therapy, and we're going all the way to last-line therapy for patients who don't have allergies or an antibiotic use within the last 30 days. So there's a lot to still digest here and work through, but I think awareness is one of the things, like Dr. Patel said, is really working with our community to really understand, the expectations, because some people are coming in 20 days in their symptoms, other people come in 1 day. So how do you balance everything in between, like the people that want to get ahead of it and the people that probably should have been in, 10 days sooner.
Yes.
Around, community education on sinusitis.
Absolutely. I think that's very, very true. Even not only are they getting antibiotics when not indicated, they're getting antibiotics that could increase the risk of C. diff, increase the risk of other complications, macrolides, azithromycin is prescribed when it's not indicated, quinolones when they're not first line or not preferred.
Right.
Dr. Munoz, please share your experience when you see these patients.
Yes. So I've been here at NGPG, in family medicine. I did my residency here. I graduated in 2024, and then I stayed as faculty. So right now I'm seeing patients in clinic as well as teaching the residents, and it is very hard, especially when the patients come and, like Dr. Patel said, or Dr. Schnibben, that they've been here like 2 days. It's been 2 days since they're having symptoms, but because they work in, they want to get ahead of themselves. So it's Friday. They don't want to be sick over the weekend. So it's very hard to change their minds because they're expecting an antibiotic, expecting something to be done because that's what they're at the doctor's.
Yeah.
But a lot of the times when I have my own patients, I try to educate them and I tell them antibiotics is not the answer for everything. And I am Hispanic, so a lot of my Hispanic patients come to me and they expect an antibiotic. So just give me an antibiotic. This is going to knock it out sooner. And I try to explain to them that bacterial infection, it's different from viral. And if you are just doing like the symptomatic treatment, such as like, making sure you increase your fluids, humidification, and teas and stuff like that, that's warm, that's going to make them feel better than an antibiotic that can cause different side effects like diarrhea, nausea, vomiting, and make them feel worse. But it is very hard to switch that mindset.
Yes, it is. It is. I think one of the things as I was looking into this, and I think for most, I think we'll all agree, they're looking for symptom relief. They want to feel better.
Right.
And I think they see antibiotics as the answer to that. In the past, when we had conversations, you talked a lot about natural integrative medicine.
Yeah.
And I think there's so many things that can be done for that symptom relief. But I think one of our opportunities is also building that confidence among the patients and community, the importance of these various things that we can do for symptom relief while we are monitoring them closely. Do you want to share what you do and
Sure.
in place of antibiotics?
Yeah. So I try to encourage patients, first to try to do the over-the-counter medications or home remedies, right? Like as you mentioned. So sinus rinses for sure. You just want to flush those sinuses out, get the gunk out of there, get the bacteria or viruses out of there. It should help. Things that will also help with boosting your immune system: vitamin C, echinacea, zinc. Those are all there to help you, and also to prevent these infections from catching on to begin with. And they're all most of the time, obviously they're safe to take most of the time for most people. There's also things like menthol and steam. These kind of things can also help just kind of drain the sinuses better, where you can breathe and congestion goes away too. One of the things I wanted to add was also like symptom-wise, when patients come in, I think a lot of times they think that just a runny nose and a headache is a sinus infection. And I think it is sometimes hard to differentiate between what's just a common cold and what can be a true sinus infection. I think duration of symptoms is really what delineates it.
Yes.
But I think that also needs to be like, taught, I guess, from the provider's standpoint to the patient, that this can be a common cold too, so sinus infection. But yeah,
I think that's one of the biggest challenges. What are the criteria we're using to diagnose acute rhinosinusitis, acute bacterial rhinosinusitis, and just to kind of put it in the mix, allergic rhinosinusitis?
Right.
Because some of the symptoms can overlap, but at the same time, I think it's important that at least with the information we have, we get the detailed history, duration of symptoms, the symptoms that they have, to give us that additional information to be able to differentiate. And you shared about some of the remedies that you recommend to the patients. And actually, Dr. Schnibben, I have this question for you that, when we have providers who actually are doing these protocols that don't have antibiotic, for those who have just less than 10 days of symptoms, not severe symptoms, I think, does it help to have like protocols developed that include these home remedies, not assuming that, all providers kind of are aware or doing it, but just maybe kind of some sort of a protocol that is easy to order or recommend, or an education thing that can be given to the patient.
I think that's a key part of stewardship. We were talking about a presentation we both watched yesterday, where when you simplify something based off a diagnosis into a one-stop shop for a provider, and we were looking at our partners over at Intermountain, they kind of had developed the same thing, and their providers just said, just make it simple.
Yes.
Make it simple for me.
Yes.
Put it in the order of operations that you want me to do. So starting off with, the non-pharmacological components, in which you include the patient education components around the steam therapy you're talking about, around menthol, and not just around, the Tylenol and the nasal decongestants, whether it's oral, topical. Be careful with topical, because overuse of that can cause rebound congestion. So you got little things and tips and tricks that you have to include in the patient education.
Absolutely.
But you go through. Let's start with non-pharmacological, that are not medication based, then non-pharmacological that are, that are, like the over-the-counter components. So you go from non-pharm to over-the-counter, then to your prescription therapies, and putting that. They said they wanted to make it so simple that when you say, this is the components that qualify for antibiotics. So going into the 10 days of symptoms, or the worsening symptoms, or what are the number of symptoms that you have to have? Because, as you said, the cough and the headache and the runny nose, those could be, but you have to have those plus the tall tale signs of, the bacterial sinusitis when we're thinking about the use of antibiotics.
Yes, absolutely. I think that's important. I think one of the things is how not just kind of utilizing our waiting rooms to share the information, also leveraging our EMR, make it easy to do the right thing. And then make it kind of, add some extra steps, or difficult to do the wrong things. Like one of the things I learned actually recent from our ID Society meeting was if they're writing azithromycin, prescribing azithromycin for sinusitis, there's a whole thing they have to check to justify the indication. Because if you look at the common organisms or common bacteria that cause sinusitis, it's strep pneumo, Haemophilus, Moraxella, and almost 70%, close to 70% of our strep pneumo in our community are resistant to azithromycin, and we're just breeding more resistance to that. Or even using quinolones when we shouldn't be using them as first line unless there's no other option. I mean, they're not the preferred medications. They come with a lot of side effects. So I think really utilizing our waiting rooms, even our exam rooms, some places have had, posters or something there discouraging antibiotic use. When it comes to patient expectations, Dr. Munoz, I know you mentioned about you talk to them, you kind of explain to them. Is there any reason why they are, when you have this conversation, are there any common things you hear? But still, give me that,
Yes, and I do tell them watchful waiting. It's important. If they come and it's Friday and they have been having symptoms for the last week, totally understand, don't want to be sick over the weekend. I will tell them the non-pharmacologic measures first, and then some over-the-counter stuff like Dr. Patel, Dr. Schnibben have said, some steroids, Flonase or mometasone, anything. Even after, but telling them make sure that you don't take it more than 3 days because of making sure that that can be rebound congestion. But also sometimes I do give them antibiotic, but tell them wait. If by Monday you're not any better, then start it. But make sure you message me, send me a message, tell me that you started the antibiotic, or tell me that you didn't. But it'll be there. I think it's just kind of like a security blanket for them, knowing that they have it just in case.
I think that's important because one of the things I think patients are also hesitant is if I feel worse, I have to come back. Another visit I have to pay for. So I think making it easier for them to communicate. And if you're doing the watchful waiting and to be able to get that, follow up, whether it's through communication through the MyChart or if absolutely needed, if they're not getting better in 10 days or they have that biphase, if they get better and then get worse or severe symptoms, that they can communicate and have a timely response. I think that will be reassuring for the patient. You brought up steroids. very touchy topic. Of course, there's the intranasal, but also the systemic steroids.
And this is Dr. Patel's soapbox.
Yeah, so I'm going to
Last 3 years, we're working on the algorithm.
So let's start
My blood pressure already. Yeah, so it's, when you try to avoid the antibiotics, right? Then the patient's like, well, what else can you give me? And so then the other tool a lot of people use is steroids. And I think in urgent care, from what I've seen, is that injectable steroids are also used very frequently because it's giving patients a quick relief, a quick fix. They feel great, their injection's gone. Next day they wake up, they have all this energy. And then they're learning that, this is what I need to have every time. And I think, again, like that, I don't think there is any, I've looked into like all the organizations that create sinusitis guidelines, WHO, CDC, ENT, AFP, you name it, everyone. Nobody recommends taking injectable steroids. They barely recommend taking oral steroids. And that's like if you're a chronic sinusitis person, maybe you're having surgery for your sinuses next week or something, like very rare cases. And yet those steroids are still very, very overutilized. And many times they are also combined with antibiotics. And patients have symptoms for like 5 days. And it's like,
and they all come with side effects. Systemic steroids are not benign medications, so they come with side effects, especially for giving to our diabetic patients. And so I think that's another one, along with antibiotics. Even though we're talking about antibiotic stewardship, management of sinusitis, I think not using systemic steroids when not indicated is another one that we really have to promote. And
I think a lot of patients are not told this. So what I've encountered is when I explain to the patient that this is what steroids do for you, this is why it makes you feel better. I guarantee it works for you to feel better, but this is why it's making you feel better. It's bumping down your immune system. So therefore the immune system that's supposed to be killing the virus or bacteria, it's not. And then when it wears off, it's going to come back with a vengeance. And that's why you're back thinking your sinus infection never went away. And when you explain that to the patients, it does take some time. And in urgent care, things are pretty quick, but if you take a minute, it does take time. A lot of them don't know that that's what it's doing to their immune system. They don't know that it's a very diffuse thing.
Absolutely.
So when they understand that, I would say probably I get across to 3 to 4 out of 10 people, which I think that's pretty successful.
I think so.
They're like, okay,
have to keep trying,
and then
we have to keep trying to educate. We have to keep trying. One of the things, speaking of patient and family expectations, one of the things that comes up we hear often from providers is, if I don't give antibiotics, that affects my patient experience scores, and then I'm compared to my peers, and mine will be lower, and there is that hesitation because that is tied to how they're compared to their peers' performance. So in your role as our quality director, Alix, I know you have been working on this. Can you share some about that?
Yeah, so we've been working diligently to, make sure that the patient experience is still there, but we still have to provide good quality care to our patients. We still have to educate them like Dr. Patel has been doing, and take that time to have that conversation, because part of things we're graded on is not only the experience, but the communication from the providers. So taking that time to communicate is also part of the components of scoring. And so, we are taking diligence to see how can we look at the data around the diagnosis that the patient received, and is there an ability to associate the providers that have those conversations and their score versus providers who may not be as willing to have it because that score is, means a lot to them. We all want to be liked, but we don't all need to be the beauty queen. It's okay to be in the middle of the pack when it comes to, because you're practicing good medicine. I mean, there are quality metrics around this. CMS does measure our ability on sinusitis about overuse of antibiotics, and then they take a sub measure and look at first line therapy around sinusitis. We're not doing that good at it, and for their perspective, for overuse on antibiotic to be considered a good fine-tuned facility around sinusitis, you almost have to be 0% on overuse. Like, all of your cases have to be more than 10 days, the sickening system, the worsening system. You have to have those qualifying things documented in the chart in order to tease out that you gave it to the correct population. So not only is it a patient experience thing, but we're also being measured on CMS around performance.
I think that's
as well.
important. I think that is important for everyone to be aware that we're being measured on the use of inappropriate antibiotics for sinusitis as well. And hopefully, as we work through our quality teams, as long as we can ensure that when antibiotics are not indicated, and that's not negatively affecting the scores, and that way providers feel supported for doing the right thing. I think that's something we've been looking into, and so I think that's very important as well. Duration, it has come up in our talk, because it's not just giving antibiotics when not indicated. It's also about giving the right antibiotic, but duration is important. What do you do when you see, especially when antibiotics are indicated? How long do you give the antibiotics, and do you get any questions from the patients for longer courses?
And I think a lot of patients will actually request the azithromycin because it's 5 days. They want that one. But then, the education is to come in where it's like, well, this is not the one that's actually going to help. There's resistance. The first line is beta-lactam, so start with penicillins, or and then you move down. But typically 7 to 10 days is what I would prescribe.
Okay, yeah. And I think this is something, and Dr. Munoz, do you want to share?
I recently changed my practice for 5 days. I looked it up and I said it's 5 days because actually one of the residents told me that and was given 5 days. And I was like, oh, okay. So I looked it up and I said, oh, you're actually right. It is 5 days now. It's not 7 to 10 days like it was before.
Yes.
And like Dr. Patel said, beta-lactams, penicillin started with amoxicillin is first. And I learned something that day, and I was happy. Whereas before we were just given augmentin for 10 days, and that was it. That was, to me, that was in my head, that was the thing that we were doing. Yes, exactly.
And I think to make it easy for us all to remember the duration also, I think we were just talking before we started recording, is like that 5 for 5 campaign for the 5 most common diagnoses when antibiotics are indicated, that giving the shorter duration, 5 days, and kind of really having a campaign around that to raise awareness, to decrease the durations for 10 days, from 10 days to 5 days. I think that'll be important as well. I think we talked about a lot of the key things that we do come across with sinusitis. Anything you think we didn't mention or missed bringing up?
No, I think the hot topics were definitely covered.
Yeah,
and using data to make it impactful.
Allergic rhinosinusitis, when I was researching about this, that is something that comes up as well. I know that can be another confounding factor with the sinusitis patients that we see with the bacterial or viral. Is that something, how do you kind of see or help? How do you differentiate that in your practice? That's a
little bit difficult to do.
Yeah.
I think most patients that have, usually when it's allergic rhinosinusitis, it's patients already know that they have a pretty strong allergies to seasonal or environmental stuff. And so then it kind of cues you in a little bit, but it is very difficult to differentiate because,
I think you're absolutely right. I think if we follow at least this very clear criteria endorsed by most of the societies when antibiotics are indicated, and we're focusing on the symptom relief with all the different modalities that all of you have recommended, I think we'll be addressing what the patients are looking for, which is the symptom relief, but still give them the reassurance that, hey, if you really get worse, or the symptoms don't improve, that we are here to help you. Hopefully that will help decrease the use of antibiotics for sinusitis. And I think working with all of you, hopefully we can develop some EMR clinical decision support tools to make sure that we're guiding the providers when to order the antibiotic, which antibiotic, the duration, and working with our PR team and our quality team, maybe work on some kind of education for the community in the waiting rooms and in any other way possible. Any last comments from any of you?
No, that would be great, because I think our community needs to be educated on antibiotic use, and I think that's very hard because that's what they're expecting. That's what has been done in the past. So changing that mindset is very hard, and it takes a lot of us, not just one person.
Absolutely, it's we're all in this together. Yeah. So I think from you, Alix.
I think we've covered it. I think we started the conversation, and that's key.
I think that's key. Yes, we've started the conversation with monitoring the data and we'll continue to work on this. Yes, thank you again for joining me today. Great conversation as usual. Thank you.